All right, thank you for joining me, either this morning or digitally, for this presentation. I'm so happy to have been invited here to the American Association of Neuroscience Nurses for this talk on functional neurological disorder and psychogenic non-epileptic seizures and spells. My name is Dr. Alex Doud. I'm a neurohospitalist at Sacred Heart Medical Center. So, without further ado, let's dive straight in. Before we get started, it's important to know the organic pathology that these conditions are emulating. And so, by way of definition, seizures are paroxysmal, disorderly discharges in the brain. And when I say this, I mean epileptic seizures. This disorganized electrical activity can cause an essentially instantaneous loss of consciousness, alteration of perception, impairment of psychic function, that means thinking and cognition, and very dramatic convulsive movements, things that we think of as seizure activity. This can also just present as a disturbance of sensation. And again, the hallmark is a sudden onset of symptoms that comes out of nowhere, the major differential being TIA, cerebrovascular events, and stroke. The original word epilepsy comes from Greek to seize upon or taking hold of, and that's what historically physicians for thousands of years have been seeing, these patients that are suddenly captured by this event. Convulsions are separate. They are intense, sudden onset of involuntary repetitive muscle contractions. So it's important to understand that a convulsion in and of itself is not a seizure, and not all seizures involve motor activity or convulsion. So those are separate, different things, and that can be particularly confusing to patients, families, and caregivers. Convulsions being the clinical appearance, the outward body manifestation of what are potentially a couple of different types of underlying episodes. There's a tremendous stigma, both historically and even to the present day, around epilepsy and seizures. The term epileptic can have significant impact on patients' lives, impact on their employment, and in Washington State, if a person's had an unexpected loss of consciousness event that doesn't have an explanation, or if they're confirmed to have epileptic seizures, by Washington State law, they cannot drive for 6 months until they have been seizure-free or and essentially on a stable dose of epilepsy medication. So we're actually quite cautious with people when they're still undergoing medication changes, even if they have been seizure-free. As a enthusiast of history of medicine, I'm going to dive into, for the next couple slides, a little bit of the painful history and misunderstanding that has come about from society's reactions to seizures and how that really played into some of the hysteria around the emergence of persecution of witchcraft in the Middle Ages. Essentially, a lot of this focus was on people with underlying medical issues, sometimes epilepsy, and definitely cognitive impairment or mental illness. And what we know is these symptoms and conditions are not new, whether it be psychogenic non-epileptic spells or primary epilepsy. These things were described as early as ancient Egypt and Greece for the last 2,500 years. Ancient medical practitioners, particularly as it pertains to psychogenic non-epileptic spells, we're starting to notice these patterns of unexplained medical symptoms that had a predisposition for, but not exclusivity to, the female sex. And we'll talk about that in a little bit. The early explanations are fairly antiquated by modern standards. There was this idea of the wandering womb, these abnormal somatic symptoms of migratory kind of internal experiences and sensations that were thought in those times essentially to be unresolved tension around the womb not being used for childbirth and becoming frustrated and moving around the body as a result. Other symptoms, globus hystericus, this sense of a knot or a mass in the throat, patients still describe that. Anesthetic regions, full body paralysis. I see these on a monthly, if not yearly basis in our patients presenting with functional neurological disorder. So a tremendously long history of these things. Other words that have been used to describe this condition or these symptoms: hysteria, melancholia, hysteric fits. And the last one in particular pertains to the description of convulsive activities that resemble seizures. So let's get into the witchy stuff. 15th century had the elaborated theory of witchcraft. There's been a lot of discussion about different types of witchcraft over the ages, but to be academically precise, the elaborated theory of witchcraft was in the 15th century, and it was a widely held theory that there was a secret female predominant conspiracy where women had formed illicit pacts with the devil with the underlying goal of undermining Christianity by damning souls and delaying the devil's inevitable defeat by the Christian God. So that is what I mean when I'm talking about the elaborated theory of witchcraft. And in 1486, the major publication that made a big splash, Malleus Maleficarum, or the Hammer of Witches, translated into German as Hexenhammer, was widely publicized, internally controversial, even within the church. And it was a description of how one could identify witches, interrogate them, and with very little evidence kind of create a socially acceptable construct by which they could be put to death. And during these trials, some of the things that people were accused of were having convulsions, causing convulsions in others. They even used the term epilepsy, so they recognized it as a medical condition. But they were saying that people in the community, often marginalized, older, potentially demented women, were the cause of this. And other things they accused them of were causing people to have leprosy, teleporting corn from one person's field to another. And the biggest fixation they had was on making men's penises disappear. They were very concerned about that. So, during this period of time, 40,000 to 60,000 low-income, marginalized, cognitively vulnerable people were put to death by fire and hanging for heresy. The vast majority of those people were Christians. The Malleus is a very evil book. If you spend any time reading it, it's interesting because of its historical context, but it devotes a major percentage of its volume in how to torture confessions, whether they're real confessions or false confessions, out of people who have been accused of this. So, in response, Sir Reginald Scot in 1584 published The Discovery of Witchcraft, which is actually a very illuminating text that basically refutes the inquisitors' proposals about the different reasons and proof of witchcraft, and he systematically dismantles that by proposing explanations for all the different phenomena and actually creating kind of unintentionally the first major description of sleight of hand and performative magic that we have in historical texts. He ultimately comments on the fact that just because these people may be forced into accusing or through accusations into admitting that they can do different things, why are we not recognizing the fact that these people have a low level of education, sometimes cognitive impairment, and kind of be bullied into thinking that they're doing things to people that they're really not. So, in the descriptions of that, if you dive into Discovery of Witchcraft, which I have, you can see a lot of great descriptions of what we would call somatic symptom disorder, non-epileptic spells and seizures, conversion disorder, and body dysmorphia. This is the only time I'll trouble you with some words from the Malleus. Again, a pretty dang evil book. For we have often found that certain people have been visited with epilepsy or the falling sickness by means of eggs, which have been buried with dead bodies, especially the dead bodies of witches, together with other ceremonies of which we cannot speak, particularly when these eggs have been given to a person either in food or drink. So they literally thought people were burying eggs with dead witches, feeding them to people, and then this was causing patients to have epilepsy. So we've come a long way, I hope. I like this one from History of Witchcraft, or The Discovery of Witchcraft by Reginald Scott. And I'm literally going to read this to you because I want you to project into this story a patient that we could see today. But the noblest example hereof is of one that was in great perplexity, imagining that his nose was as big as a house, insomuch as no friend or physician could deliver him from this conceit, nor yet ease his grief or satisfy his fancy in that behalf. Till at the last a physician more expert in this humor than the rest used this device following. First, when he was to come in at the chamber door being wide open, he suddenly stayed and withdrew himself, so he would not in any wise approach nearer than the door. The melancholy-like person, musing hereat, asked him the cause of why he so demeaned himself, who answered him in this manner. So the physician's coming in, he's making a big show of being avoidant of the guy, and he says, "Your nose is so great, but I can hardly enter your chamber, but I shall touch it and consequently hurt it. Lo," quoth he, this is the patient now, "this is the man that must do me good. The residue of my friends flatter me, and would hide mine infirmity from me. Well," said the physician, "I'll cure you, but you must be consent to endure a little pain in the dressing," which he promised patiently to sustain, and conceived certain hope of his recovery. He's basically saying, this guy gets me. Then entered the physician to his chamber, creeping closely to the walls, seeming to fear the touching and hurting of his nose. Then he did blindfold him, which being done, he caught him by the nose with a pair of pincers, and threw down into a tub which he had placed before his patient a great quantity of blood, with many pieces of bullock's liver, which he had conveyed into the chamber while the other's eyes were bound up, and then gave him liberty to see and behold the same. Having done thus again 2 or 3 times, the melancholy-like humor was so qualified that the man's mind being satisfied, his grief was eased, and his disease was cured. What applies to psychogenic patients today from this story? Caring for these patients depends on establishing rapport, and for people who have been dismissed, whether by their friends, by other physicians, "Hey, your nose isn't so big," they feel like they can't even engage in the beginning of the healing journey. Helping patients feel heard and not discarded by the system, this comes up an awful lot. And when you think about the reasons that patients are consciously or subconsciously manifesting a whole wide array of symptoms, it comes down to this: hear me, understand me, right? Ease my way. By engaging in the patient with where they're at, we can start to dismantle the patterns that are leading to the dysfunction and distress. So this physician acknowledged the patient was having a lived experience of body dysmorphia. And there's different schools of thought about how much to deceive people and use placebo effects, and that can be discussed at length. But there is balance between employing effective techniques and maintaining community trust in the medical establishment. Because if everybody knows that when they come to us for help, we're tricking them, that doesn't create a trusting society that's willing to engage in medical practice. I believe there are ways to invoke some of this healing without kind of overtly lying to patients, and that's what I try to do in my practice. So in 1603, we started to make some progress. Edward Jordan, in The Suffocation of the Mother, proposed a relationship between mental illness and the symptoms of melancholia. There was still a lot of fixation on unresolved womb issues, and that's still persisted for a very long time. The uncomfortable part about that is statistically somatoform disorders and psychogenic non-epileptic spells are more classically described in people of the female sex. With that said, I think it's misrepresented and underrepresented in males because they do not necessarily come to medical attention in the same way or produce the same sorts of symptoms. Interestingly, and we'll get back to this kind of near the end of the presentation, in 1603, a young woman, Mary Glover, developed left-sided paralysis. She lost the ability to speak, She had abnormal movements of the belly and prolonged seizures. And basically a house cleaner, Elizabeth Jackson, was accused of bewitching her. Jordan, the author of this text, was summoned to testify by the king and basically said all of this is caused by, physical and mental causes, not by witchcraft. And it speaks to kind of the prevailing wisdom. This judge, who saw the trial, says, "This land is full of witches. They abound in all places, and I've hanged 5 or 6 and 20, so that's 26 people. Just for this, I don't care about your judgment unless you can prove this is caused by the body. Kind of go screw yourself." Mm-hmm. And you can recognize that in this judge, he has a lot of kind of stake in the idea that, the fact that he's condemned a bunch of people to death for really, medical and not spiritual reasons. There's a lot of momentum to change that mindset, right? It's ingrained, and there's a certain probably internal guilt around that as well. Mary Glover ultimately was sent for exorcism. Elizabeth Jackson, possibly because of the defense by Edward Jordan, was not executed, but she was forced to publicly confess her crimes and then spent, I believe, the rest of her life in jail. Charcot with Salpêtrière Neurological Hospital became chief of neurology, and he continued to propose that the centrality from a standpoint of organ system for these conditions was the brain. And he was the first one to say it should be treated like any other neurological disorder. Charcot spent a lot of time working with hypnosis in these patients, and he found that you could both produce the symptoms and alleviate them through hypnotic methods, which remains true to this day. He spent a lot of time photographing these patients, and so some of the first photographs and lithographs we have of psychogenic illness is basically these handful of 3 women who were well known to Charcot and studied over time. There were a lot of patients that kind of amassed within his hospital, and one of the complicated sort of double-edged swords to treating psychogenic illness is when Charcot died, a lot of them stopped having symptoms and left. I think there was a kind of a give and take of that attention that he was paying to some of their lived experience. This is one of those lithographs from Charcot's work. This is arc to circle. You'll still see this sometimes in psychogenic non-epileptic seizures. It's not a thing that epilepsy does. It just doesn't. So this is kind of one of the hallmark original manifestations of psychosomatic and non-epileptic seizures, arc to circle. So, speaking a little bit about epilepsy, about 200 million people in the US have it. There's about 44 new cases diagnosed for every 100,000 people, and slightly less than 1% of people will develop epilepsy by age 20. The majority, 66% or so, arises in childhood, with a second bimodal increase in people after their 60s. A previous version of this talk talked about epilepsy in older people, but there is a kind of bidirectional relationship between dementia and new onset seizures, and so there's a disproportionate representation of dementia in aging patients with epilepsy, and in patients with dementia there's a disproportionate increase in unrecognized seizure disorders, which, while we can't reverse the symptoms of dementia, if we do recognize those seizures and treat them, cognitive impairment and cognitive decline can sometimes be halted dramatically in early onset dementia. None of these statistics account for people who have provoked seizures, seizures from fever, especially in childhood, drug use, critical illness, trauma, etc. So in terms of somatic symptom disorder, functional neurological disorder, prevalence, symptoms in different clinical studies not associated with a detectable underlying medical disorder are common. Up to 20% of young or middle-aged patients and 13% in older adults And in a survey of primary care settings, up to 15% of patients coming to medical care complained of different symptoms of no clear structural underlying origin. As the DSM-5 revised criteria for somatoform symptom disorder, around 3% of the general population and 7% of medical patients meet criteria for those disorders. In some studies of Scottish neurological symptoms, what we do know about these patients is they have similar reported levels of disability to patients with underlying medical conditions. There's a higher level overall of distress in these patients, and there's a higher tendency to be without work and on prolonged medical disability due to these symptoms. And as a medical establishment, neurologists generally think that these patients are more difficult to help. And on longitudinal study, only rarely do these patients sometimes develop underlying neurological diagnosis when they're followed. However, there is comorbidity that's important to recognize in epilepsy and PNES. That's psychogenic non-epileptic spells or seizures. Estimations suggest that up to 10% of patients with PNES may also have comorbid epilepsy. What that means is when someone develops a diagnosis of epilepsy and then has separate psychogenic events, oftentimes we will respond to any new event with either the addition of a new anti-epileptic medication or increasing doses of the epileptic medications that they're already on. This has a lot of risks in terms of potential side effects, toxicity, and those effects are kind of aggregated over time as patients are exposed to these drugs for longer and longer. Because when patients do have a comorbid diagnosis of psychogenic seizures, it can take up to 7 years or more on average to realize that. Most of the time when someone receives a diagnosis of epilepsy, the question is not readdressed. And fairly recently in my clinic, I've been referred patients who actually their epileptic seizures are under very, very good control, and we're continuing to chase with epileptic medications events that are not epileptic seizures. Video EEG is the gold standard to differentiate between epileptic and non-epileptic seizures. In general, EEG will tell us the answer. There are a few very rare subvariants of epilepsy, mostly frontal lobe seizures, which can look very unusual, where EEG may not be revealing of abnormal appearance, but it still is epilepsy. Some of the clinical criteria that can be useful is when patients are having episodes out of sleep. Those are very often epileptic in nature. That doesn't mean patient woke up, went to the bathroom, came back, was still awake, and then had an event. That still could very much be non-epileptic. Or a patient woke up even for a moment, looked around, and then had an episode. These are really truly emerging out of sleep. Those are very, very rarely psychogenic, although that's not ubiquitously true, even within my own experience with these patients. Thrashing back and forth movements, alternating convulsive movements that are not synchronous with each other, are not generally epileptic, and retained consciousness despite full body bilateral contractions are essentially incompatible with epilepsy. In order to manifest convulsions in both sides of your body, both hemispheres of the brain need to be actively convulsing with electrical activity, which is incompatible with consciousness. So, from a nursing standpoint, when you're asking patients about these symptoms and when you're doing things like checking if they can recall words from during their episodes, those things are very, very helpful diagnostically. And sometimes the patients change in terms of what they're saying. Sometimes they'll say, I lose consciousness, but when you really dive in, could you still hear things? Could you still see things? Could you still feel things happening to you while this was occurring and just not be able to interact? that sort of episode is much more compelling to be a non-epileptic episode. Okay, so asking those questions at the time it happens is very helpful because sometimes we can't get that information back after the fact when more time has passed. Is that the end? Huh. No?
It's not the end.
Oh, yeah, I put this as my last slide, but I think I'll just make a quick little plug. I'm trying to build community engagement in Spokane around FND and psychogenic non-epileptic seizures. We're starting to do non-medical community-based support and education. And so if you're interested in contributing or participating or getting patients involved in discussions with a group of their peers, we're holding those sessions over Zoom, and patients and providers can get more information at fndtransformed@gmail.com. In terms of describing and classifying seizures, when a patient suddenly has one of these, especially when they're under your care, it can be very difficult to not immediately attend to them, and it can be easy to lose track of some critical information. So these are the things that I want documented from a neurologist standpoint. I want to know, in addition to taking care of your patient and keeping them safe, what is the sequence of events of the seizure? Is stiffening going to happen first, and then the shaking? Is shaking happening first, and then the stiffening? The order of events actually defines semiologically tonic-clonic versus clonic-tonic seizure, for example. Are the patients vocalizing? Can they still speak, interact, or show some sign of consciousness? For some patients, that may be as simple as showing a thumbs up. Again, that changes dramatically the type of seizure I think that they're having. If someone's having full convulsions, but they can still show a thumb, some people use American Sign Language, some nod their head or can stick out their tongue to command, it's worth to try those things because it radically changes the diagnosis potential, even if they're not hooked up to continuous EEG. How long does a seizure last? That's important both for kind of definitional criteria. Seizures lasting longer than 5 minutes meet criteria for status epilepticus, and clusters of seizures expanding beyond 5 minutes, even shorter if each individual event is shorter, but there's no return to baseline consciousness, that would again meet criteria for status epilepticus. The reason that matters is because we think of those time marks as time periods where there can be more profound and lasting metabolic damage to the brain, and when the seizure can reach a point where it can become much, much more difficult to treat medically. So documenting how long it lasts, and once it's over, how long does it take for the person to return to baseline. Seizures present danger to patients through 3 primary mechanisms. Some of these apply to epileptic and non-epileptic seizures. So I talked about repetitive disorderly firing of neurons. That can metabolically exhaust the cells. That's not going to be happening in non-epileptic seizures because internally there's no electrically driving repetitive neuronal firing event that's causing these. And again, in epileptic seizures, lack of breathing from tonic phase, falls, excessive muscle movements, tongue biting, all those things can produce injuries. And of these, right, patients with non-epileptic seizures, one of the kind of myths is that they cannot harm themselves during these episodes. That's absolutely not true. They can fall, they can hit into things, lacerate themselves, and have an episode when they're doing an activity that could cause harm to themselves or another person, and they don't necessarily have a subconsciously active protecting mechanism that keeps them from doing that. Other causes of mortality include traumatic injuries, motor vehicle accidents, MIs, right? Just getting that activated, whether it's psychogenically or epileptically, can cause undue strain on the heart. And at least in epilepsy, there's this phenomenon of sudden death at night. The patients who are more susceptible to SUDEP are going to be those ones who are not on anti-epileptic medications, who have had epilepsy for longer, since an earlier age, and who struggle with issues related to developmental delay. The kindling hypothesis refers to the idea that having a seizure produces a more entrained neuroconnective network that can make seizures more entrenched and difficult to treat. So getting ahead of them, making sure they're managed, and counseling patients that they should be reliably on their medicines is all very important. We've talked about status epilepticus. I'll just say briefly that the overall mortality has historically been 20 to 30%. We're doing a lot better, I think. And also there's different flavors of status epilepticus, right? A patient who has a seizure for 6 minutes technically meets criteria for status epilepticus, but that's very, very different from a patient who's been continuously convulsing for 20 minutes, which also meets that definition. So to some degree, the potential for lasting harm has to do with the seizure itself. So that's where documenting that information is very, very helpful. Not every sudden loss of consciousness is either epilepsy or psychogenic non-epileptic spells. Syncope, cardiogenic drop attacks, panic episodes, and dissociation events, disorders that arise out of sleep like REM parasomnias, sleepwalking, etc., sudden halting of breathing overnight like in sleep apnea, are all things that can mimic seizures and non-epileptic spells. And I think this is important, right, because if a patient has syncope from a cardiac issue and they're put in the EEG monitor, the epilepsy monitoring unit, and they have loss of consciousness, maybe even convulsions, right, because in syncope you can have post-syncopal convulsions from transient cerebral anoxia. You look at their EEG, it may not show seizure activity. That doesn't mean it's a psychogenic non-epileptic seizure. You need to do a thorough medical workup to exclude, some of these other causes. So I'm going to talk briefly about EEG, because it is the gold standard of detecting this. It's based on electrodes placed on the surface of the scalp. We measure voltage differences between them and basically reference all of the electrodes to a neutral point on the patient's body. Voltage changes are represented by sampling very, very frequently, 128 to 256 hertz or cycles per second. And so we get a waveform that shows us ongoing neuronal activity in the brain. So this is what we're familiar with seeing at bedside. We can actually change the dynamics of this montage by clicking, different ways of comparison. Whether we're comparing a single electrode to its neighbor, as is happening in this particular study, or referencing an electrode to the global ground reference. These waveforms, as you can see, consist of a lot of different frequencies, high frequency activity overriding slower waves, and basically we're looking at and naming each of these different frequency ranges, and that's how we can describe in the EEG reports what component is most present. Vast majority of people awake and alert are going to have alpha and beta frequencies. As you get more sleepy, theta frequencies, slower waves emerge, and in deeper sleep you'll see delta. That's a very, very rudimentary kind of simplification. This is a top-down view of the 1020 International System for electrode placement, and it basically is a convenience system so that we can describe easily where different waves are coming from. The letter refers to the brain region, whether it be temporal, frontal, frontal polar, occipital, parietal. Left-sided numbers are odd, right-sided numbers are even, and Z is basically the midline. So this gives us a standard method of discussing where certain waves and spikes and seizures may be emanating from. And the amplitude is just how tall these waves are, which can vary according to the patient's anatomy, the skull, how well the electrodes are fixed, etc. And so we use all of these factors to describe what the waves look like, and that's how our epileptologists guide us in terms of what's happening with the brain. EEG and EEG interpretation is a subspecialty within neurology, so Not all neurologists are going to be familiar and comfortable with reading EEG waves. So it's certainly not the responsibility of nursing staff to be interpreting in real-time EEG. But if you do see something abnormal, it's always appropriate to alert the on-call physician to either take a quicker look or get in touch with the epileptologist, especially if things are changing dramatically. There can be large spikes in abnormal appearing EEG, which is actually attributable to patient movement, and having the video on can really help and discern that. I'm going to speak briefly on Cerebell. Cerebell is a useful tool with tremendous limitations. It has one major job, and that's to rule out generalized, ongoing, non-convulsive status epilepticus. So to break that down, that's a patient who should not be moving or moving very, very minimally. They should not be awakening or responding, and they shouldn't be actively convulsing, because if they're actively convulsing, we kind of know what's going on to a certain extent. Now, with that said, if we strongly suspect a patient of having non-epileptic seizures, it's sometimes reasonable to put a Cerebell in place when EEG resources are not available. Because again, like I said before, generalized bilateral convulsive actions of the arms and legs would be caught on Cerebell as a convulsive seizure, and incompatible with consciousness. Now, Cerebell may get lucky if a focal seizure is happening directly under the headband electrodes, and Cerebell will, promotionally tell us it can capture focal seizures. Yes, and it can also miss a lot of focal seizures. So you can catch one that way, and that's diagnostically valuable if you do, but a negative Cerebell, a study that's said to be normal, does not exclude the possibility of focal seizures occurring in a location that Cerebell is not covering. Cerebell generally has no role in an alert, awake, interactive patient. That doesn't mean they wouldn't love it for you to apply one to that patient, because it pays Cerebell's bills, but not an appropriate use of the resource. Importantly, Cerebell has an algorithm that is called seizure burden. It is expressed in percentage, and basically what it's looking at is a metric of rhythmicity, okay? But it doesn't definitively determine whether a seizure is occurring. So if you're having elevated seizure burden percentage, it's good to let the on-call neurologist know that, and then be in touch through the institutional protocol with the epileptologist, who will visually inspect that waveform and make sure it is indeed seizure and not toxic metabolic issues, which can occur in patients with diverse arrays of medical illness. So not infrequently, we will get patients started on anti-epileptics, and the EEG reader will review the Cerebell and say, seizure is not occurring and it never has been. EEG captures data in real time. It shows us a seizure itself, and it can also capture intraictal activity, which, if a seizure is a brush fire, I call intraictal activity sparks and smoke in the grass. It's showing a predisposition for that area to become epileptically active, and a potential statistically for that patient to have seizures. Sometimes intraictal findings, so even the absence of a seizure itself captured on EEG, is enough for me to initiate an anti-epileptic medication in a patient who I suspect has been having seizures. EEG is very valuable for capturing and characterizing abnormal episodes. So when patients and families, potentially patients who have seizure history, are wondering, is this new episode a different kind of seizure, we can use video EEG to differentiate between things which are seizures and those which are not. And that can be a tremendous benefit to patients and families when they're trying to understand whether to escalate medical care in response to different types of events. I talk to patients and families about the red button, what it is and what it isn't, and where there's some confusion here. The red button attached to the EEG machine is a marker. It's like putting a bookmark in the EEG record. Remember, every page of EEG is 10 seconds, and our epileptologists are looking at 12, 24, and sometimes multi-day studies of continuous EEG. So when you calculate out what 10 seconds divided by 2 days is. It's a tremendous amount of data. And so if we're seeing specific episodes of concern, pushing that red button marks the record so that the epileptologist can review the specific location of concern. What it doesn't do is it doesn't alert anybody. It doesn't make the epileptologist look at that region immediately. They're often reading these in long chunks and living the rest of their life being in clinic, going to sleep, and then waking up to review large chunks of the study periodically. So if an emergency response is needed, pressing the nursing button or getting a respiratory code or whatever else is necessary to kind of escalate that medical care. This is important for families too, because unfortunately the nursing call button is also red. And so when we tell patients, hey, push the red button if something happens, sometimes they're sitting there spamming the nursing call button all night, and we don't have any indication of where in the EEG record we should look the next day. Things that are really helpful that have been conveyed from our epileptologists, especially for bedside staff. Patient is not in frame for the video recording. The machine gets moved around, shuffled around. We really want to be able to see the whole patient. We want to be able to see arms and legs. Of course, people want to be underneath covers, but if patients are so bundled that they can't be seen at all, and especially if we know the thing we're looking for is subtle hand twitches, that's not going to be valuable. We won't know if we captured things or not. Big pet peeve of our epileptologist is well-meaning family members clustering around the patient and obscuring the camera, especially if every time the patient has an event they do that. Again, we lose valuable data and kind of the whole point of what we're doing. I spoke about the ambiguity between different types of red buttons. And one thing that can be really unfortunate is sometimes the EEG gets set up and the red button is coiled around the EEG machine in a way that it's not accessible to the patient or family, and they don't want to mess with it, right, because it's part of the medical equipment. Another big one is sometimes patients are taken to a procedure, imaging, x-ray, etc. The EEG is transiently unhooked and then it's not rehooked. And unfortunately, sometimes we lose data for huge spans of time when that occurs. So working closely with the EEG techs to make sure that the system for connecting and disconnecting is achieved correctly is tremendously important. We're still having those sorts of issues even up to present times. So now we're going to do a few cases and discuss. Here the patient presents with report of ongoing convulsive movements of the arms and legs. Family says this has been going on for 2 hours prior to arrival of EMS, so we'll talk about it, but that's a prolonged seizure. That's one that we would be very concerned about. With all of that said, it immediately raises the question in my mind, what were we doing for those 2 hours, and what changed at the 2 hour mark that suddenly said, oh, now we need medical attention? Something in my brain goes, okay. Patient retained the ability to speak short sentences, took American Sign Language in high school and could spell out a few simple words like water. Family brought them water, let's say. They drank some and then they continued convulsing. Again, kind of atypical. Woke up briefly, was able to ambulate to the bathroom, washed her face, returned to the couch, and the convulsions continued. She fell off the couch, hit her head, got a scalp black from let's say a glass coffee table, and then had incontinence of urine or stool. Medics arrived, convulsions continued. They were concerned about her airway and they intubated her. And in the field they gave 8 milligrams of IV Ativan and 20 milligrams per kilogram of IV phosphatidone. In contrast to some of the cases that I present, this one I did build for the purposes of illustration, but it's not at all outside of the realm of what I see on a fairly regular basis. So, we can ask these kinds of questions, and for the purposes of the digital session, I'll kind of do the Blue's Clues thing and wait for you, and you can answer, right? But what kind of seizure is this patient exhibiting? Probably a non-epileptic seizure. You're right.
You're so smart. That's what
and does she meet criteria for status epilepticus? Yes, she does by time, right? And at the point we don't have EEG data and there's other things going on, it's fair to say that she's in status epilepticus, and there is PNES status epilepticus, so psychogenic non-epileptic seizures that meet criteria, and it's basically time criteria like anything else. But the other possibility is she's having brief returns of consciousness, she's having focal seizures, maybe they're brief, maybe they're causing her to remain altered and not coming back to baseline, but they're allowing her to communicate, right? So these things help us vote in different directions, but they're not definitive without some EEG or more information. What are the symptoms for generalized tonic-clonic seizures? It's going to be that first tonic phase of stiffening, right? Followed by clonic, myoclonic jerking, typically rhythmic, not alternating frequencies, not changing, and discoordinated movements. Sometimes it can be really hard to tell. People ask you things like, is it rhythmic, is it arrhythmic? That can be very, very challenging to notice in the movement, specifically if the patient is positioned in an abnormal way. Are there atypical features in this patient's presentation? Yes. The retained ability to spell with ASL, the fact that she got up, walked to the bathroom, came back, and then started doing it again, those are things that are going to push me more in the in the non-epileptic direction. What questions do you have about this case as we prepare to manage this patient? You can think about those as we prepare to discuss further. So this patient is now connected to EEG overnight. The EEG shows generalized slowing and no seizure activities detected, and so carefully we lighten her sedation. She's weaned from propofol and fentanyl. She's extubated and transferred to the acute care ward, and EEG remains in place, and it eventually becomes normal. So one thing that I'll say here is when these cases come in, one of the first things that I try to do is remove, excessive sedation, because even if it met criteria for status epilepticus, I don't know if this was maybe a 7-minute seizure with well-meaning intubation for airway protection, or if we're still actively seizing when we lighten meds, and I want to know that soon, because it can prolong patients' time on the ventilator and increase the risk of iatrogenic complications like, any of the complications that can be intrinsic to a prolonged ICU intubation. So I will walk into the room oftentimes and I'll say, turn off propofol, turn off fentanyl. If approved by your ICU team and heart rate is not bradycardic, transition to Precedex, which will help the patient remain chill, but will allow them to resume a normal mental status so we can assess them. And then I'll be in close discussion with our EEG reader to make sure that no seizure activity is re-emerging. Typically, within 30 minutes or so, we can start assessing the patient for subtle signs of return to consciousness, following commands, opening eyes to voice or tactile stimulus. And a word on following commands. I really want to know, and it's very helpful in nursing documentation, what sort of commands they're following. So if you put your hand or fingers in the hand of a sleeping person, a lot of them will squeeze, whether they're awake or not. Squeezing hand doesn't tell me a ton, although it's the beginning of something that's a good sign. The other one that doesn't help me much is moving feet, especially if the patient is going and, every couple minutes or so they wiggle their toes, and you may coincidentally say, hey, wiggle your toes, and they happen to do it, right? I like very much more stereotyped commands that a person would not spontaneously do unless given the verbal command received and understood. So show me a thumbs up, show me 2 fingers, show me your pinky, stick out your tongue. There's actually a remarkable tendency for patients to follow central commands before peripheral commands. So open your eyes, close your eyes and blink 3 times. Those sorts of things can return, and they can be an indication that consciousness is returning. So for this patient, she comes in, she's been extubated, her family visits her, and as they're getting ready to leave, the patient has another convulsive event. After 3 minutes, she gets some more Ativan and the convulsions stop. But we go back to the EEG reader, and this time we realize that at no point during any of this was the patient ever demonstrating ictal or intra-ictal activity on the EEG. Now, the EEG initially is normal and then transitions to generalized slowing with superimposed beta frequencies. You may see that in the report. And now for you at home, why might that be? That's right. She was given Ativan, and that caused her waves to slow down. Beta frequency emergence is also a finding associated with benzodiazepine administration. So that is not seizure activity. Her brain got sleepy because she got Ativan. So what is the diagnosis? Psychogenic non-epileptic seizure in this case. And it's confirmed by gold standard video EEG. As some talking points, due to the complex nature and variability of seizure subtypes, I never definitively diagnose or refute a seizure, at least in my own mind, based on a clinical description, but I start voting one way or the other in my mind and eventually come to a clinical conclusion. The diagnosis requires a combination of clinical observation, EEG findings, patient history, right? Does this patient have a history of other somatoform or functional neurological behaviors? Oh, I remembered back in college, I stopped being able to move my legs for a few weeks, right before exams, and then I got better and they never figured out why. So that kind of history can be really, really helpful. Patients return to baseline after a prolonged 2-hour episode where she, got up and walked to the bathroom. That's very, very atypical. Again, if we're proposing the alternative, which was that she was having continuous convulsive seizures, that's going to have a post-ictal phase that isn't going to be just suddenly ambulatory. I'll state briefly that the return to baseline is also helpful diagnostically for other neurological conditions. Syncope, cardiogenic episodes, syncopal convulsions. In general, those patients should be coming back to baseline within a couple minutes to their baseline mental status, whereas in epilepsy, especially prolonged seizures, that post-ictal recovery can be between hours and days sometimes. And oftentimes, admissions will be lengthened just because we're waiting for that post-ictal encephalopathy to resolve. Soiling with urine and stool, I'll say briefly, an injury to the tongue is not universally confirmatory of an epileptic seizure, especially the soiling stuff. I will say in general, tongue biting is compelling for an epileptic seizure, but what I'm really looking for is lateral tongue lacerations. Psychogenic non-epileptic seizures may cause a biting of the tip of the tongue, but very, very rarely the lateral aspects. So another really useful thing that you can document is the presence or absence of a lateral tongue laceration. That can be tremendously helpful. So what helps in the management and treatment of psychogenic non-epileptic seizures? Well, the gold standard and evidence-based treatment pathway involves cognitive therapies, cognitive behavioral therapy, dialectical behavioral therapy, psychodynamic psychotherapy, and all of this relates to basically examining and understanding triggers. The first thing I tell my patients to do when they see me in clinic is begin first with an understanding of the condition. So we do counseling under understanding these and what they are and what they're not. And then we start documenting and gathering data, typically with a tracking system. That can be as simple as a journal, or it can be a complex tracking app like the EPSI app, which is originally made for epileptic patients, EPSY. But it's great for tracking any sort of sudden onset episodes. So patients can talk about triggers, they can talk about symptoms, they can talk about durations, and the app automatically tracks when the things occur. You can even embed video if you have a friend or family member who can record that. And so all of that is very, very valuable to bring to clinic sessions, because what we're looking for is the pattern. Is there anything that consistently triggers these? And one of the first things patients tell me in clinic is no, they can happen completely out of the blue. I don't get any warning. But when we actually look at the data over time, we can start to see trends in terms of what's going on. Patients and families, I try to educate them with direct and honest communication. A lot of people, even with our best efforts, walk away saying the doctor says it's all in my head. And I've done my best effort to avoid that. And I've even gone so far as to saying, hey, this session's going to end, and there's a 95% probability that you're going to walk out and tell someone the doctor thinks this is all in my head. I get ahead of that. And so I try to kind of shift that narrative and explain through a little bit more lengthy counseling why that's not entirely untrue, but it doesn't speak to the whole picture. Patients ultimately need a narrative that preserves identity, ego, and gives them a narrative that they can either share with others or choose to withhold from others. Because many of these folks will have invested a tremendous amount of time and resources into their medical journey, whether it be lost time in the emergency department or lengthy, painful, and invasive diagnostic procedures. These patients are somewhere in between psychiatry and neurology, and I use that as a statement to say, hey, this is why this is hard to understand. Okay? And basically what we're trying to create here in Spokane is a comprehensive multidisciplinary outpatient pathway for longitudinally managing these patients, not just for their own well-being, but also from a resource stewardship standpoint in our community. And I would say at this point, the single biggest barrier is getting people connected with this CBT, DBT, and psychodynamic psychotherapy counseling. In general, I don't have any problems with patients doing EMDR. A lot of patients ask about that. I think it can be very valuable. Some providers are hesitant or will even exclude patients with a question of underlying seizures. Personally, from my standpoint, I don't see a tremendous risk there, especially for people who do not have photosensitive epilepsy, and if the provider is able to provide alternate modality stimulation alternating side vibrotactile stim. So, what's our time right now? How long
It's
have I
about
been?
11.
Huh?
We have about 25 minutes left.
Sure. Okay, so in terms of my approach to these patients, first and foremost, I want them to feel seen and attended to, just like the guy with the nose back hundreds of years ago. Your problem and your lived experience is real, and I'm going to try to engage in helping you with it. And so I start the interaction with very active listening, right? I try to hear the symptoms, but I also try to hear which parts are causing the patient most distress. Because unfortunately for my poor medical assistants in clinic, they try to do a review of systems on these people, and literally, I have a few pictures of reviews of symptoms where they've circled every single thing in the whole thing. And so then we're 20 minutes into the appointment, the MA is still trying to do an ROS, and I finally got to say, hey, we're going to dive into the most important component here. I always do a very thorough neurological exam on these patients, whether or not I feel convinced of the diagnosis. And if the patient's bored by the end of it, I know I've done my job, okay? I look for inconsistencies in the exam, elements where the patients are emphasizing what a layperson would think the exam would have if it were abnormal, right? So drift, okay, it's drifting, but in a certain sort of way. Can you remember 3 words? And they just absolutely can't. You're looking for, is there some sort of, in the same way as a positive review of systems, are they consistently altering the exam consciously or subconsciously to bring my attention to the issue, right? Because again, they want to be seen, heard, and understood. And I'll say briefly, of course, I'm looking for underlying health issues and organic abnormalities in the exam that could talk about a comorbid issue, because sometimes psychogenic illness will flare when the body's in distress from some other cause, heart failure, cardiac issues, etc. So being vigilant is very important. I think we've talked enough about EEG. Here's a few inconsistencies that I like on exam. There's many, many more. Giveaway weakness. This is where I'm pulling as hard as I can and then I stop pulling and the patient stops pulling too. Or I pull on them and then suddenly they give away in a way that doesn't feel like weakness, it just feels like discontinuation of effort. I really like, I don't think there's a name for this, but like clock sign where, I tell them to maintain their anti-gravity and I count to 5, and it's like 5, 4, 3, 2, 1, or even better than that, okay, hold your arm up, and they like throw it down faster than gravity would. That's another good one. Drop sign is that when you hold an arm above their head, they avoid their face as it comes down. Drop sign can be a little bit of a trap, because I think drop sign is not as appropriate for assessing partial weakness. People who have a little bit of residual strength still don't want to hit their head. It's really appropriate when a person says, I can completely not move my arm at all, it's completely plegic, and then I hold it up and it's inconsistent with that prior finding. Stuttering, and I'm going to say this carefully because this is almost always true, there's a few neurological exceptions. True stuttering, repetition of words, but I can't speak, is almost never of primary organic neurological origin. And so actually the presence of stuttering, just like a lateral tongue lack, is a really, really helpful thing, and documenting it really helps me out. Inability to speak with retained ability to communicate using an alternate modality, sign language, writing perfectly fine but mute. Those things don't pathophysiologically make sense because language is separated into, right, the ability to have that expressive language component, to articulate using your motor apparatus. And so mutism with preserved ability to write is hard to localize neuroanatomically. But the patients don't know that. So sometimes when they're presenting as the mute person and they want to talk to you about something, giving them the out of being able to write is a helpful thing both diagnostically and from a communication and rapport building standpoint. Another motor inconsistency I really like, maybe they're drifting quite quickly, but if I tell them to do finger to nose, they can reach out and keep touching my finger for a really long time, like sometimes the full 10 seconds. That's inconsistent. Sudden ability to use a limb when the necessity demands or examiners are not obviously looking. My favorite story of this was I had a patient who was completely plegic during a stroke code. He was getting ready to get carted away to imaging, and I said, here, real quick, I just need you to sign something before you go to imaging. I was careful not to be deceptive and say, you need to sign this for your imaging, but he picked up the pen with the plegic arm and signed it for me, and so again, inconsistent, right? And we'll talk, but I sometimes do hypnosis adjacent activities to aid in my diagnosis because these patients are very suggestible, and to a certain degree that suggestibility has taken the wheel, right? And that's almost part of what the problem is, and so using other types of rapid kind of hypnosis and suggestion can sometimes help to diagnose or alleviate activities. That's kind of hard to do and takes a little bit of experience. It's very case specific, but I am finding with repetition there's some consistent things that work. So here's a few critical pieces I want you to remember. The vast majority of patients with psychogenic illness are not consciously fabricating exam features. There definitely are some patients who are. They hold separate diagnosis, which is factitious disorder, a fancy way of saying faking it. Munchausen's and Munchausen's by proxy, where basically either for themselves or to another person, they are fabricating or actually producing illness, right? Injecting insulin or bacteria into their IVs to create detectable medical illness and assume the sick role as kind of the secondary gain. But I will say secondary gain is difficult to understand, right? The presence of a potential subconscious secondary gain may be present with FND and PNES. Some patients are safety seeking in different ways at a subconscious level, maybe from an unsafe home or an unacceptable sort of social situation. And the presence of the condition helping them with that does not mean secondary gain in the same way that these other conditions do. Patients who do have a direct cognitive understanding of manipulating providers in order to get something are really, really difficult to help. And basically I don't engage those patients in therapeutic pathways for FND. Okay? So the patient needs to understand a few things from us. They need to understand that we believe, whether we believe that their illness is caused by an organic medical condition, we believe that the lived experience they're going through is real, even though there's not a structurally detectable cause for it. The patient, and this is a big one, must be released from blame for these lived experiences. And I say 5 words can tear down walls and change the entire nature of an interaction. And I try to give the patients the experience of hearing these 5 words because it may be the first time they've ever heard them. And sometimes I repeat them until they sink in. The 5 words are, "This is not your fault." And I'd say about 95% of the time people break down and cry from that. So it's important to choose your moment for that. But that's something therapeutically that can be done that really connects strongly with the patients. It's important that patients learn that there's others like them experiencing similar challenges, and with guidance and understanding from the medical team they can get better. And that's the truth. There's a myth that these folks just are a revolving door that never improves. That's absolutely not the case. So there's a couple of metaphors that I use when I'm counseling the patients, and the first thing that I say to them is understanding FND is like a sculptor with a block of marble. There's no single thing that I can say that'll make it all make sense at once. But if we have enough conversation and we talk about it in a couple different ways, we can gradually chip at that marble in a way that it can become understood. And the first thing from my sort of generation that I introduce is this kind of famous web comic by Casey Green on Fire from 2013, the "This Is Fine" dog. Because when we ask these patients, hey, are you under stress? And that's what a lot of doctors do. They say, hey, this could be psychosomatic. We'll ask if they're under stress. The vast majority of these patients will look like the dog. They'll say, no, I'm not having any stress at all. And let me tell you, in 2026, with the world that we're experiencing, a person who has no stress at all is very rare. I kind of don't think those actually exist. Okay, so the point where someone is not recognizing that, there's a strong likelihood that the house can be on fire and they're not giving that conscious attention. Okay. And I tell them 2 other quick stories, the kettle and the turtle shell, and I think that these are pretty helpful. They're stories meant to illustrate some of the underlying components of FND that can be hard to understand. I tell the patients, imagine a kettle. A kettle is made to take the heat. It's intended to be put on the stove, and part of what it does is it takes in and builds up pressure. That's part of its job. A kettle built correctly has a pressure release valve, and it has a whistle to tell whoever's making the tea that it's time to remove the kettle from the heat, right? If, and I ask the patients, if for some reason, right, which we can talk about at length, the pressure release valve is not present, the kettle is in danger of an explosion, right? And if the whistle is not present, when the kettle has reached a heat level that is requiring it be removed from the stove, there's no way to inform and notify that that's the time it needs to be taken away. This is the time in the session when I start to talk to patients about trauma. And I'm very, very careful to say, hey, this container right here is not necessarily the appropriate place for us to dig in and unearth all the details of your trauma. If you want to share, you can share as little or as much of that with me as you want. But all I want to tell you is that in human development, an organic, normal human brain going through development, which we think lasts into mid-20s or beyond, that's been exposed to a constant or even temporary state of trauma, changes its ability to perceive what is crisis and what is not. And so that pressure release valve acts differently in people who have had that lived experience. And instead of exiting in a way that's kind of whatever normal is, right, that can flow out into the nervous system and the body. And part of how we rebuild that whistling mechanism is by manifesting neurological symptoms that can help us seek safety, to keep ourselves safe when for one reason or another we feel unsafe, right? And that's where I come to the turtle shell. The turtle shell is an intrinsic part of the being. It grew with it, it's there to protect it, and when the organism needs to withdraw from an unsafe circumstance, it's able to do that. Now, it pays a price for that. It pays a price in terms of freedom, and it pays a price in terms of mobility. And it's easy for a doctor to say, oh, that's just a maladaptive coping mechanism. All you need to do is just take off that shell and you'll be fine. But the thing about it is they won't, because it's part of the being. And if you take the shell off of the turtle and don't replace it with anything, the turtle's going to die, right? And I tell the patients that this is a serious thing, because what we know is when a patient receives a diagnosis, when they're stripped of that defense mechanism or invalidated to their family and friends, those patients can die. And they can die from self-harm, and they can die from basically loss of resources and loss of, their normal ways of coping with the world. So it's very important that if we do this, we're not just diagnosing and discarding these patients, but helping them enter a pathway towards building more effective tools. So what do? I let the patients know the condition has a name. I tell them just having a conversation about that name is the first start to getting better. And I give them the expectation that maybe doing this might be part of that. I provide them with the website FND Hope. It's a great place to see and experience and check their symptoms against what's described, and let them know that there's people like them out there. I let them know that the diagnosis is not enough. They need to take these next steps in the journey. And the single thing I ask them to do, if they can do nothing else or remember nothing else about this condition, is to do anything they can to establish care with a trauma-informed psychotherapist, start engaging in CBT. And I explain that CBT is a process of stepping back from your thoughts, learning to examine your thoughts, and redirect thoughts that are taking you in a particular direction that may not be advantageous, and steering them in a direction where you can feel, like you're moving in a more productive direction. And that is a skill. It takes time, and it takes a person who's familiar with it to help guide patients through that process. So we're going to skip that part, but basically these are a few cases that I just briefly saw in my own practice. They do kind of speak to some of the kind of rapid hypnotism, mindfulness, and relaxation stuff. But basically the way I started doing this is I said these patients sometimes have nothing other than their breath, and breath work, mindfulness, meditation, even something as simple as a body scan or a progressive relaxation can be really, really effective in these patients. When coupled with suggestions about symptoms improving, that can be very, very rapidly powerful. And so in the first case, I have a 51-year-old male. He's been all over the country presenting to emergency departments. In this case, he entered our system as a stroke code. He had right-sided hemiparesis, dysarthria, and stuttering speech in the past. He'd had TNK on at least 3 prior occasions. This time he came in completely mute, but he did retain the ability to write. He had a couple of conditions that boxed him out of useful diagnostic imaging. One included an allergy to iodine, so he couldn't get a CTA, and he had a spinal stimulator which prevented MRI. I took him through basically a rapid-fire breathing exercise. And one of the things I tell these patients beforehand to set expectations for the potential for healing is I say this next part is safe, but it's going to feel really weird. And I say take in 3 deep breaths, breathe in through your nose, out through your throat, 3 times, and then I reach out my hand. I offer them to shake my hand. This part's a little bit weird, and it comes from hypnotism. But basically, as he's about to take my hand, I take it away, Charlie Brown style, and I tapped him 4 times in the middle of the head. When we start shaking a hand, it initiates a pattern of spinal reflex arc. Our conscious mind shuts down for a second because we're doing the handshaking thing. And I hit him with something completely unexpected. And I said, okay, now I want you to keep breathing. I take out my tuning fork. I put it on his forehead and I say, start feeling this vibration moving through your head, out through your face. And this is the expectation setting. I don't make promises, but I said, I think for the next several minutes you will be able to speak. And the guy goes from being mute to going into stuttering. And that's great. So, with the stuttering, now I reinforce the idea that this is psychogenic, and I say, great, I celebrate this. I say, you punched through the hardest part of the barrier. Now that the speech is flowing, it's going to keep flowing from here. And he's immediately mystified. He said, what the heck happened? How did you do that? I said, don't worry, we're going to talk about it. You're going to go get a CT scan. So he went and got a CT scan. I did the same thing basically one more time, and then he was able to speak normally. I was able to avoid TNK based on resolution of deficits to non-disabling symptoms. So, weird, right? But I had the prior knowledge of what had happened before, and so I felt safe that these were stereotyped episodes. He'd been adequately worked up on multiple occasions. If this was his first time doing this, I would have imaged him even more aggressively, and I would have been very, very thoughtful about whether I was going to offer TNK even with a low suspicion. Good news is you can always get out of TNK if you can get their symptoms to completely resolve, because one of the exclusion criteria is you don't give TNK to people with no neuro symptoms. So sometimes I'm just shooting for that. It's been 423 years since Mary Glover, but if you remember, she's the girl who got, symptoms that led to that court case, right? And the imprisonment for life for witchcraft. In our ED a couple months ago, we had a 50-year-old female. Has a history of bipolar, fetal alcohol syndrome, so some developmental delay, ICA stenosis, migraines, and she's come multiple times for episodes of hemiplegia, again, left-sided weakness, left facial droop, and she can't move her arm or leg at all. She has an interesting habit of coming in right at the deadline for TNK, so there's a lot of pressure to consider giving this. This particular case was during 4 simultaneous stroke codes. So I had 2 patients hung up in the scanner. I had another one who had just been confirmed for bleed, and now I have this patient, and she's right on the cusp of TNK. In this particular instance, this was the first time I tried the rapid induction thing, because I just was like, I'm going to try this to see if it works. The ED providers had a little bit of prior experience with this patient, and they told me she comes and does this often. Her workups have always been negative, so I had a bit of confidence that this may work. And again, I asked her to make her best attempt to move her arm and leg, because I wanted to make sure that symptoms were just not already resolving on their own. She absolutely could not. It was fully hemiplegic. And so again, I assured her she was safe. I counted to 3. I snapped my fingers next to her, and I tapped her 4 to 5 times between the eyes. And again, without promising things, I said, I think you will find that you can now move your arms and legs. Show me that that's the case, right? And that subconscious mind was able to take that suggestion. Her strength immediately returned, and her, in this case, I put the tuning fork on the arm and the leg, and I said, can you feel this? She said, yes. And I said, as you feel the tuning fork dying down, I think you will find that the strength in your arms and legs is returned to normal. I then tested and confirmed that for her, and she had 5 out of 5 strength in all tested muscle groups on the left. So again, I was able to avoid TNK because, again, her neuro exam went back completely to normal. Now, if I did this 423 years ago, I think there's a decent chance I would have ended up on the pillory rather than the other person, and so I think you got to be careful with these sorts of things. Just briefly in closing, for the 2 patients I just showed you, this is 1 year from the time that the patient saw me in terms of resource utilization for each of these patients. Blue's the guy, orange is the gal. So what you can see is for each of them, well over 20 emergency department visits in a single year, 10 hospitalizations, in one case, something around 14 or so MRIs. And so it's just a tremendous amount of resource utilization, and with a little bit of knowledge and compassion for these patients, the hope is that we can break the cycle. So with that, in the words of David S. Pumpkins, any questions?
Thank you. I do have some questions.
Okay?
Okay. Is this continuing to be recorded? All right, I'll keep some of the questions. All right.
He can edit things.
Okay,
Yeah.
fantastic.
Ask your questions.
So one common question that's on our floor, so I feel like I'm speaking for a lot of our, both nurses and NACs when I'm asking this question, is we have our LTME patients where we have someone at bedside who is responsible for pushing the red button in the case of a seizure-like event. Then we have other patients who are on continuous EEG who it's unclear if there's an expectation to do a push button event for. So not every patient gets on continuous EEG on our floor, gets a bedside sitter, and we are not confident that each of those patients are going to be able to press the button on their own. And sometimes we're not asked to do a push button event at all. So can you help give us clarification on what are the expectations of the nursing staff for these patients?
I would say in general, if you are in the room and the patient has an irregular event concerning for a seizure, it's reasonable to push the button. I don't think necessarily the expectation, if there's not staffing and safety, that someone has to be hovering and monitoring for that. But I would say the easy way to answer that question is, again, it's a massive amount of data, and it's helpful to have markers in the record when interesting stuff is happening.
Okay.
So without that being an absolute requirement, if anyone, including family or me or, someone is there and they see the patient behaving in an abnormal way, or if the patient says something like, hey, that was unusual, it's always appropriate to help and facilitate that pushing of the button. And I would err on the side of push rather than don't.
Okay.
And it's helpful to speak into the camera to say, hey, the patient experienced this, or I saw that, because they can actually hear the recorded audio, and that helps know. Because sometimes they'll see the push button and they'll be like, what the heck happened? I'm not sure what they're talking about, but an easy way around that is always just to...
I like to say I'm pushing the button because I'm seeing periorbital lip smacking and things like that. It's like I like to narrate my actions
And that's
to the
really
patient,
helpful.
family, and the camera. Yeah.
Yeah, that's really helpful.
Interesting. So it's interesting that you use the tuning fork vibration. I know there are, and this I'm assuming is from something you chose not to touch on, which is your possible training in hypnosis. Is that true?
So the tuning fork...
You're given that when you become a neurologist.
The tuning fork is...
Oh!
The tuning fork is kind of an interesting history, okay, especially with me. And I think different people do this sort of differently. As you advance in neurology, you start molting tools. When you're an early resident, you have all this stuff, and you're trying to carry it around. Ultimately, I don't have my tools on today, but I have a belt with 3 different slots in it. This is for my reflex hammer, this is for my flashlight, and this one's for my tuning fork. And most people discard their tuning fork fairly early in their, or they have it accessible, they don't carry it around with them all the time. Strictly speaking, 128's tuning fork in the hands of a neurologist is usually for testing of large fiber sensory loss. So it gets you out of a lot of why is this old man falling consults. Because if you establish that a person can't feel vibratory sensation in their toes, that means that they have pretty bad large fiber neuropathy, which is going to cause proprioceptive ataxia. So that's the official reason I actually was always carrying my tuning fork around. I joke with the residents and the medical students that, when I signed up for neurology, they gave me these 3 tools. I knew what 2 of them were, but the third one I didn't know what it was for, so I just started trying it on people. And
that's when I laughed when you asked your question.
Got it.
He's told me that before.
and it sort of kept working, and so now I do all sorts of things. Now, vibratory therapy has a long, complicated history, both in natural medicine traditions and allopathic medical conditions. Some of that is really complicated, but I think that there's something special about a pure vibration. And so I actually have sort of like debated in my own head to what degree is that absolutely pure placebo, and to what extent does it actually help like relax, ground, and clear people. And so I've kind of stopped asking myself that question, and I know that it's a disruptive force in the same way that tapping someone in the middle of the head, hardly anybody knows what the tuning fork is. That means they don't know what it can and can't do. And so when I set the expectation, hey, I think this might help, I think you may find this can help you. At this point, going back to the guy with the nose and deception, when I say that at this point, I'm actually not lying. Because at this point, I've cured a large amount of people with psychogenic mutism using relaxation techniques, snap hypnosis, and sort of tuning fork stuff. And so when I tell the patients, I tell them, look, I have some experience with this condition. Sometimes for some people this helps break through, so let's see if that's the case for you. And that's the expectation I set around that. And my tuning fork has been used for a lot of things in that regard. I've used it for hemiplegia, I've used it for mutism, and kids love it because it sounds kind of like a lightsaber. So yeah, that's my shtick on the tuning fork and why I continue to carry it. I actually, on a few occasions for patients who are really intractable, and the tuning fork really, really helps if they don't have a whole lot of access to, medical resources. On one or two occasions, I've just told them, hey, if this helps you and you understand that there's nothing magical about it, whether there is or not, I give them the tuning fork and then I go find a new one. So, yeah.
That's cool. I guess that kind of was my question too, is when you help somebody through the form of, I think what you said was psychogenic mutism, or I think you also used rapid induction technique. Should I know that already?
That's sort of hypno-adjacent terminology. An induction is induction into trance, and I'm kind of careful about saying, at this point, actually this year, I'm pursuing formal certification with the American Society of Clinical Hypnotists as part of what I'm using my CME for. But I've kind of stumbled into that. And the way I did was at first, right, I was just somebody who had done some breath work and progressive relaxation, guided meditation, relax, ground, and clear, progressive, motor relaxation where you scan through your whole body and tense and untense your muscles. In my research work as a grad student in biomedical engineering, I did some work with Yoga Nidra as a method for modulating EEG, and I found that people who had mind-body awareness training could actually learn to modulate their EEG better than people who had never been exposed to that. So I kind of resurfaced some of that relaxation, at first just trying to see if it could help people relax in the emergency department. And I found that putting people in that sort of state, you become more and more receptive to healing suggestibility, and it's a short dance from there into things like hypnosis. Wow. So a rapid induction in the hypnosis world has to do with putting a person into a receptive state, using very rapid techniques rather than sitting with them for an hour and going through a whole kind of formal classic hypnotherapy session. So that's where that comes from. Thank you.
So I guess, is this something that just helps in the moment, or is it something that can help them long term? My question being, does she represent?
So in the case of the first patient, there are issues around level of cognitive function, and it is tougher for people who have cognitive disability, and so the counseling needs reinforcement. In the case of that patient, within our system, she presented more, and the documentation was adequate to help streamline the presentations and avoid unnecessary testing in T&K. As soon as she went to another system, she actually ended up receiving T&K again after my session. But having continuity with me in clinic, it was useful to be able to touch base again, reinforce, kind of what we talked about in the past. And I tell the patients, one session with me where I do whatever to resolve symptoms, the analogy that I use is I'm like a GPS, right? I help you navigate to the place where you're trying to get to. And the idea is once you walk that path or drive that path, ultimately nothing that I do, whether it be with suggestibility or hypnotism or any of those things, I tell the patient, you don't lose control of your mind, it's not mind control, right? I'm helping your own internal process get to where it needs to go. And once you've used the GPS enough to get there, you'll be able to get there by yourself. And so that's kind of the goal. So that doesn't happen overnight, but I think having a dramatic recovery like that and then me deconstructing it for the patient saying, hey, I don't have a secret power, this is you, and I helped amplify your own internal abilities, is something that they can take and carry forward. At least I hope so. Yeah.
Thank you.
All right, thank you everyone.
Thank you so much.
Thank you.